Good afternoon, everybody. Welcome to the third cardiology session. We have a number of interesting speakers, and we're probably going to be pushed for time, so we'll get started. Do you want to?
Hi, I'm Sharmila Dorbala from Boston. I'm here with Dr. Robert Mansberg. We are both moderating this session. We have 4 very interesting talks. The first talk is going to be cardiac CT, current status, diagnosis, prognosis, and incorporating the NICE guidelines. This will be delivered by Professor Sujit Seneviratne from Monash Health in Melbourne.
Thank you very much. Thank you for inviting me. It's a great pleasure to be here. I'm going to be talking on the current status of cardiac CT, in particular looking at the diagnosis, NICE guidelines, and prognosis. These are my disclosures. So we'll briefly touch on the cardiac CT technology today, and we'll review the cardiac CT evidence for stable angina. We'll talk about NICE guidelines, and as I said, prognostic value of cardiac CT at the end. As you all know, the traditional way of investigating stable chest pain is to do a clinical examination and take a history, and usually through a functional study, whether it is nuclear stress test, exercise stress test, or stress echo, and then finally, if required, a coronary angiogram. And in US alone, there are 4 million stress tests happening every year. However, there is problems with this system. If you look at this study of 400,000 patients, or registry of 400,000 patients, 40% in fact had normal coronary angiograms based on this model. And only 1 in 3 actually have obstructive disease, which is defined as more than 50% stenosis. And in that population, 84% actually had functional testing. And if you have a positive stress test, 59% actually had no obstructive disease. And if you have a negative stress test, 28% actually had obstructive disease. So while this has been a safe strategy for many years, there are certainly deficiencies with this strategy. On cardiac CT, on the other hand, is a relatively simple anatomical test rather than a functional test. And as you can see in these images, the first image shows the curved MPR showing severe stenosis in proximal LAD. And you can see the volume rendered images and the corresponding angiogram. Now, cardiac CT has evolved rapidly over the last decade and a half or so, with significant improvement in slice numbers, spatial resolution, temporal resolution, and scan time. And if I just briefly sort of summarize the 3 important parts of the scanning technology, the spatial resolution, or the geographical information, has improved from 1.25 millimeters down to 0.3 millimeters, which is not very far off from angiography. The temporal resolution, or the shutter speed, has gone down from 330 milliseconds to 66 milliseconds. So no longer patients have to hold their breath for long periods of time. The longitudinal scan coverage, or Z-axis, is also significantly improved over time from 64 slices, so it started with 4 slices, and now 320 slices covering 16 centimeters. So the entire heart can often be covered with a single rotation. So how does it compare with the invasive angiography, which is the current gold standard for an anatomical test? Cardiac CT's maximum spatial resolution is 0.3 milliseconds, and angiography is 0.2 milliseconds. The temporal resolution is certainly better with angiography, 66 compared to 8. And radiation dose is between 1 to 3 millisieverts in the new generation scanners compared to 5 to 8 millisieverts on coronary angiography. I'm not going to go through the accuracy studies being published quite some time back, and this is just some studies comparing invasive angiography with 64-slice cardiac CT. The very basic message is cardiac CT is highly sensitive in excluding obstructive disease. Therefore, there are only very few false negative studies. So excellent accuracy in excluding coronary artery stenosis. So earlier studies with cardiac CT was mainly concentrating on establishing its place in terms of accuracy. The cardiac CT has moved on, and the more recent studies have been having an impact on what is its use in clinical practice. So let's talk about some of the evidence we have for cardiac CT to be used in the setting of stable angina. In fact, there are 2 large randomized controlled trials in the last couple of years, and also a large registry that I would like to bring your attention to. The largest of these was a North American-based study called PROMISE, which looked at 10,000 patients, and they randomized to an anatomical-based testing, which is cardiac CT, versus functional-based testing. And nuclear stress was 2/3, stress echo was about 23%, and exercise ECG was about 10%. And there was a 12-month follow-up with a median of 25 months. Now, if you look at the results, this is major adverse cardiac events during the follow-up period. There was absolutely no difference. So while the assumption was that the anatomical based strategy would be superior, it did not identify any difference at the end of the follow-up period. However, there were a couple of issues with this study. One was that it was a low-risk population. So in fact, there was only about 11% of the population out of the 10,000 had more than 50% stenosis. And the event rate was only 3.1%. And the power calculations was that if you were to show a difference between anatomical versus functional testing, given it's a stable angina, therefore low-risk population, you have had an event rate above 8%. So it was well below. But nevertheless, it was completely a negative study, no advantage with cardiac CT. The second study came from Scotland, or Scott Hart study, which was about 4,000 patients, again randomized. And the randomization was to standard of care. The standard care was a usual assessment in outpatient setting, followed by an exercise stress test. And then the other group was standard of care, which included the exercise stress test, and then added cardiac CT to that information. And they came back after the cardiac CT after about 4 weeks, or about sort of 4 to 6 weeks, and the results were looked at and discussed. And the primary endpoint was how confident the clinician was in making the final diagnosis of angina secondary to coronary artery disease. Now, by adding cardiac CT, the clinician was able to clarify the diagnosis in 25% very clearly, altered the downstream testing in 17%, significantly reduced the number of normal coronary angiograms on angiography, and increased the likelihood of obstructive disease on angiography. I suppose these are not too surprising. Now, what about the hard outcomes? The hard outcomes, as you remember, in the PROMISE trial, there was no difference. And when you look at the fatal and non-fatal myocardial infarctions, this is a much higher disease prevalence. As you can see, the disease prevalence, unlike 10% or 10 to 11% in the PROMISE trial, this disease prevalence was 42%. And what you can see, the curves sort of diverge after about 6 weeks, and there is a clear advantage to cardiac CT over stress testing. However, the statistical significance was only borderline significant. When you analyze this, if you remember that the implementation of the outcome, implementation of the strategy based on cardiac CT happened at about 6 weeks when the patients came back with the results of cardiac CT. So if you exclude this initial period of 49 days when nothing really happened apart from standard of care, and once the cardiac CT results come in and once the strategy changed, and if you look at that time period, there is a 50% reduction in the combination of fatal and non-fatal myocardial infarction. And these results are still significant at 2017 update. So very substantial difference, although relatively small numbers when it comes to 3 years, a difference being shown. So for the first time, a diagnostic strategy has influence in reducing outcomes in a stable angina cohort. That's never happened before. And a meta-analysis, which I'll show a little bit later, also when you combine the two trials, it still showed that there is a reduction in the myocardial infarction risk. Now, the next one I'm going to touch on is a registry. And of course, as you know, that we don't pay the similar kind of attention that we do pay for randomized controlled trials when it comes to registries. However, Danish registries are slightly different in that they are able to capture their entire population. So therefore, it still does count. So this is a very large population of patients, 86,705 patients, and about 53,744 had a functional test. About a quarter was actually nuclear stress testing, remaining were exercise stress testing, and 32,961 had cardiac CT. This is the way of investigating stable chest pain. And then these patients are followed up for a period of median of 3.6 millisieverts. And again, what you can see is a very similar message. There is no difference in all-cause mortality, but the myocardial infarction risk is reduced. And if you combine those all-cause mortality and myocardial infarction, it is still reduced by about 30%. Now, this was combining those two randomized control trials and the Danish registry from Ron Blankstein published in JACC. And what you can see again, the myocardial infarction risk when you assess stable chest pains with cardiac CT is reduced by about 30%. However, there's a price to pay, and if you look at both these studies, the revascularization rate has gone up. And in both the studies, there was no statistical significance, but there was clear trend to higher revascularization. And again, more angiography was also likely to be performed in a CT-based strategy. And what you can see is that there is also change in how you treat the patient. So there is significantly more patients being treated with preventative therapies when you do a CT-based strategy. And we'll come back to that when we talk about prognosis a bit later on. So let's talk about NICE guidelines. So essentially, these two randomized controlled trials had an effect on writing up the new NICE guidelines, which are UK, the guidelines for their healthcare system. These were updated in November 2016. Now, this is gone from one extreme to the other extreme. And in this strategy, they departed significantly from their previous guidelines from 2010. In 2010, they were pretty much asking the physicians to assess them clinically and come up with a risk score. And then, depending on the risk score, classify them into low, intermediate, and high risk. If you're high risk, you go for angiography. If you're low risk, maybe do a calcium score. And if it is abnormal cardiac CT, the great majority of the patients, or the intermediate risk category, was functional imaging. And they were suggesting that we should not do exercise stress testing because the accuracy is low. So the functional imaging was their cornerstone in assessing chest pain. Now, this is completely changed in November 2016 guidelines. Now there is no risk score assessment. All what you're doing is basically assessing them clinically and deciding whether they got typical angina, atypical angina, or angina not due to cardiac cause. And cardiac CT is the first line investigation, whether you got chest pain, typical or atypical, or if you even thought it is non-cardiac but had suggestive ECG changes, cardiac CT was still the first line management strategy. Now, the functional imaging is now a second line investigation. It was only recommended to do functional imaging if the cardiac CT result was not clear, or if the patient was already known to have ischemic heart disease. Therefore, you want to assess the burden of ischemia. And coronary angiography was now considered a third line investigation. So just to summarize again, the clinical likelihood or the risk scores were gone. The zero calcium score was no longer used to rule out coronary artery disease in low risk population. The first line investigation is now cardiac CT for both typical and atypical chest pain. And functional testing is only if the CTCA is not diagnostic or if the patient has already got known coronary artery disease. However, there are issues with this strategy. Now, while these are the recommendations in UK and that is being put into practice at the moment, they are struggling because they don't have the cardiac CT scanners to implement in every single hospital. If you look at the ESC guidelines, they haven't changed yet, and they are significantly different from the current ESC guidelines updated last in 2013 or ACC-AHA guidelines from 2012. Both of which predominantly recommend functional imaging as their choice. Now, another problem is that standard of care that against which cardiac CT was compared in Scott Hart was exercise stress testing, and it is not functional imaging. So we know that exercise stress testing is inferior to functional imaging. The third thing is that in recommending cardiac CT as the first line investigation in UK, they assumed the cardiac CT cost would be very low. And that is not the case in most countries. And they also assumed that the radiation burden will be very low, given that most people will be using the high-end scanners, and they thought it's 1 to 3 millisieverts, but that's not always the case, particularly if you're using the older generation 64-slide scanners. And of course, as I said before, they certainly can increase the angiography and revascularization rate downstream, and therefore not entirely sure about the cost-benefit all the way up. So what about the prognostic value of cardiac CT? And when you look at prognostic value of cardiac CT, typically calcium score comes into mind, and we're going to hear about calcium score in the next talk. But what I'm going to talk about is what is the value of cardiac CT in prognostic sense. And it is important to realize there are 3 different kinds of prognostic information which is available. One based on whether patient's got obstructive disease or obstructive disease versus no obstructive disease, whether the patient got plaque versus no plaque, and thirdly, what type of plaque or what kind of plaque the patient is having. So this is confirmed registry that you may have heard from James Min, looking over 24,000 patients, and simply James classified them as to having obstructive disease. That means over 50% stenosis versus non-obstructive disease. And what you can see is if you got no atherosclerotic plaque at all on a cardiac CT, you have a warranty period of about 5 to 7 years. Your risk of actually annual death is 0.28%. So normal cardiac CT means you usually do not need to do further investigations around 5 to 7 years. And as your number of vessels with obstructive disease increase, your mortality increases. And that's been repeatedly shown in a number of other registries. Now, also very important to realize that it is not just obstructive disease which is important, but also non-obstructive disease. And if you look at this study of about 2,500 patients, what you can see is compared to having no plaque at all, if you have one vessel disease versus two vessel disease versus three vessel disease, but still all non-obstructive, your mortality actually goes up by 6-fold just by having non-obstructive disease in all three vessels. So that's very important information that we all need to realize. And finally, going back to the PROMISE trial, and if you look at the PROMISE trial, and if you think that revascularization actually reduces cardiac events, that is not the case. Most of the events actually happen in patients who actually have normal test. Normal is defined as a negative myocardial perfusion study or a stress echo, or less than 50% stenosis in cardiac CT. But great majority, in fact, more than 85% of the events actually happen in what you call normal stress test or normal cardiac CT. When you look at more information, one of the deficiencies with this functional imaging is that you only have a positive or a negative test. It does not tell you what the plaque burden is. And the advantage of cardiac CT is you can tell what is somebody's risk and what is the plaque burden. And what we can see here is that if you actually have a normal cardiac CT, in other words, no atherosclerotic plaque at all, only 10% of that population will actually have an event. So 90% of the events happen in either obstructive or non-obstructive disease. Whereas in functional imaging, 50% chance when the stress test is negative, they're going to have an event in the follow-up period. So that is an issue, and that's a significant advantage in favor of cardiac CT. And so then what we can look at, how did cardiac CT influence these outcomes? So how did cardiac CT improve the risk of myocardial infarction? In fact, in Scott Hart, once you know the cardiac CT result, 1 in 4 patients had their statins and aspirin changed. So some people had their aspirin and statins taken off, other people added. So the real advantage of doing cardiac CT and why actually probably made the difference was these preventative therapies targeted appropriately. And perhaps why it didn't make a difference in the PROMISE trial was that the rate of statins were low, and even when the CT was available, they hardly made any difference. And perhaps that's why it didn't make a difference in outcomes with PROMISE trial. So finally, prognosis can also be judged on the type of plaque. And this case is from Monash, and you can see on the left side, there is a patient with a proximal LAD stenosis. You can see it's a large non-calcified plaque with a little bit of spotty calcification, and the lumen is not compromised. And you can hardly see there's a stenosis on the corresponding angiogram, and that's what you call positive remodeling. If you got these characteristics of positive remodeling, predominant non-calcified plaque, and spotty calcification, at least in a relatively small series, they have a significantly higher risk of having acute coronary syndrome as opposed to stable angina. And in the bottom graph also shows what the risk is having acute coronary syndrome versus only having stable symptoms. Large calcification is protective, whereas spotty calcification and low attenuation plaque and positive remodeling increases your risk significantly. And perhaps these patients need to be more aggressively managed. So in summary, cardiac CT provides excellent negative predictive value to exclude obstructive disease. And there is emerging evidence that assessment of chest pain by cardiac CT reduces risk of myocardial infarction, driven primarily by directing medical therapy to appropriate high-risk group. NICE guidelines now recommend cardiac CT as the first-line investigation of chest pain. And of course, I've demonstrated that it has also got issues with that as just one-size-fits-all strategy. And there is strong prognostic data to be gained through cardiac CT, providing a unique opportunity to modify future risk. Thank you.
Thank you very much, Sene, who's going to be returning shortly. We might leave the questions till the end because we're going to be running tight for time. The next speaker is Dr. Stephen Stowe from Palmerston North, New Zealand currently, and previously from Boston in the United States, who's going to talk about...
Florida.
Florida? Oh, sorry, Florida.
I have a good Boston accent.
Who's going to talk on CT coronary calcium scoring in chest pain patients improves the prediction of adverse cardiac events independent of SPECT myocardial perfusion imaging. Thank you.
Kia ora and good afternoon from New Zealand. I'd like to thank the organizers of the meeting for inviting me. It's a great honor to speak here with such an august faculty. Well, I'd like to start off with a scan from our institution. And this is a attenuation correction, non-gated, low-dose CT of the chest that we use as part of our protocol for myocardial perfusion imaging. And what you can see here is there's very clear heavy calcification of the left main, left circumflex, and the LAD. Now, if I was to tell you that this patient had a normal perfusion scan, that information, the additional information of coronary calcium score, might impact your management of the patient, as we saw from the previous speaker, might impact your use of antiplatelet agents or statins. So CT coronary calcium scoring in chest pain patients can improve the prediction of adverse cardiac events and can change management independent of the results of the SPECT myocardial perfusion image. Well, coronary calcium scoring has been around for a long time. It was originally developed by Dr. Agustin, and this was a trial using the Agustin score called the MESA trial, which was published in the New England Journal of Medicine about 10 years ago, showing that coronary calcium in asymptomatic patients is able to risk stratify patients into high, intermediate, and low risk groups. And those patients with a coronary calcium score of 0, the yellow line there, have an extremely low 5-year cardiac event rate. So it's very predictive of low risk for cardiovascular event. So again, no coronary calcium in patients over the age of 40 males or over the age of 50 women indicates no coronary atherosclerosis. Well, what about chest pain patients? That was asymptomatic patients. This is a nice study from Methodist Hospital, which patients without known coronary disease presented to the emergency department at Methodist Hospital and had a normal troponin and normal ECG. And within 24 hours, they all got a coronary calcium score and a stress spec functional perfusion imaging study. And what the study showed that if patients with no history of coronary disease present with chest pain and have a 0 coronary calcium score, they have extremely low subsequent cardiovascular risk, less than 1% cardiovascular event rate at 6 months. And this was more predictive, a 0 coronary calcium score was more predictive than a negative perfusion, SPECT perfusion image. So once again, the absence of coronary calcium in the coronary arteries is predictive of the low-risk patient. Again, I want to emphasize using coronary calcium score in men less than age 40 and women less than age 50 is suspect because they don't have time to calcify their coronary atherosclerotic plaque, and they could still have non-calcified plaque and be at risk for cardiovascular events. So you want to keep that in mind when you're assessing coronary calcium. But in those patients other than this group, detection of plaque equals detection of coronary calcium, because coronary calcium accumulation is equivalent to plaque burden, and as plaque develops, coronary calcification intensifies. And what's interesting here, you can have moderate to advanced coronary atherosclerosis with normal functional perfusion imaging It's only late in the course of the disease do you get symptoms and abnormal perfusion or obstructive coronary artery disease. So having a normal perfusion scan, as the previous speaker described, is maybe giving you a false sense of security in that you think there is no atherosclerosis, but in fact, they have non-obstructive coronary disease and have significant coronary atherosclerosis and have a significant risk, as we'll show later, of adverse cardiac outcome. So when I came to Palmerston North, they were not using the CT attenuation correction scan for any information at all. The information being obtained from the chest CT attenuation correction scan was just used to do attenuation correction. And what we started doing is using a visual ordinal scoring system to look at coronary calcium. What that did, it added a new dimension to our interpretation. The dimension was anatomical. So it was not only a functional test we were doing, the myocardial perfusion scan, we were also doing an anatomical test, looking at coronary calcium. And this study from the Netherlands was a major epiphany for myself. And Dr. Better came over from Australia and helped us start our lab and demonstrated to me how easy it was to visually assess coronary calcium. But we weren't able to obtain the Agassiz gated software and hardware because in New Zealand we have significant budget limitations. So we started scoring calcium visually. And then this article came out which convinced me we're on the right track. This study from the Netherlands shows that as coronary calcium score increases, the chance of a functional test being abnormal increases. But interestingly, at severe coronary calcification with an Agassiz score greater than 1,000, you only have 50% of the patients having an abnormal functional test. So you have half the patients with significant plaque burden having a normal functional test. And that has significant prognostic implications. As we see here, patients with severe coronary calcification with a normal functional test, a normal perfusion test, 5.5% of them had a major adverse cardiac event at 1 year. And that was about the same as having a positive functional test with moderate to severe calcium defined as an Agassiz score of 400 to 999. So that is an important point I want to reemphasize, that the asymptomatic patients, a coronary calcium score is a strong, very strong independent predictor of events, irrespective of the SPECT study. SPECT study can be normal, but if you have a severe coronary calcium score and high plaque burden, you still have significant risk. And then conversely, patients with zero coronary calcium had extremely low cardiovascular event rate. So a zero coronary calcium score, as shown in the MESA trial and in the study from Houston, coronary calcium score of 0 is associated with less than 1% major adverse cardiac event rate at 1 year. And it didn't matter if your functional test was positive or negative, you still had a very low cardiovascular event rate, less than 1%. So the anatomical test adds significant value to the functional test. So I know the NICE trial and all these other trials are looking at anatomy versus function. What I'm saying, we can marry the two and have a happy marriage. So once again, just to emphasize, independent predictive value of a zero coronary calcium score, no matter what the perfusion scans showed in this study from the Netherlands, a patient with a zero coronary calcium score had less than 1% cardiovascular event rate. And then conversely, a normal functional test, a normal SPECT perfusion study in blue here, had a 5% major cardiac event rate at 1 year in patients with severe coronary calcification, defined as a coronary calcium score greater than 1,000. But the marriage of the two is the most beautiful. And that's when you have both an abnormal functional test and an abnormal coronary calcium score, a severe coronary calcification. Here you can see normal perfusion at rest, and then development of inferior perfusion defect with stress associated with severe coronary calcification. These patients who have both severe calcification and positive functional tests have the highest risk. So there's a complementary of the anatomic information and the perfusion information here. So in summary, in symptomatic patients, coronary calcium scoring is a strong independent predictor of events, irrespective of the functional SPECT myocardial test, irrespective. It provides incremental information regarding the degree of coronary artery disease, and routinely performing coronary calcium scoring in those groups that have a hybrid CT SPECT or CT PET study, you can add significant prognostic and diagnostic information and get a better understanding for the risk of subsequent cardiac events. Well, let's switch gears now and talk about my poor man's calcium score. And what I mean by that is this is a visual interpretation that's scored with an ordinal scoring system that we use called the Chamish score. And Barry Allison came up to me and said, you're going to talk about the proper coronary calcium score. What she meant by was the Agassiz score, which is a gated study of a higher dose CT with automated software that's been developed to detect coronary calcium. But what I would suggest is the poor man's coronary calcium score is just as good. And why is that? Why don't you need gating and higher dose CT imaging? The reason is that coronary calcium has a high attenuation value. It's very bright. And you can see in this study here, the coronary calcium is as bright as the bone. And if there's no coronary calcium, it's very obvious, and this LED here is normal. And it's very obvious that there's a very bright attenuating substance of calcium in the coronary artery in this patient here. These are low-dose, non-gated CTs of the chest. And this has been validated in multiple studies throughout the United States, Europe, and Australia. The visual interpretation of low-dose ungated CTs is equivalent to regular dose ECG-gated CTs. And this is a study where there was one observer who ranked the Agassiz score based on the two different modalities, non-gated and gated, and found equivalent. And visual scoring of coronary calcium has also been well validated. This is the study that we refer to validate what we're doing, which is an ordinal scoring system of coronary calcification on low-dose, non-gated CT scans of the chest. And it's been found to be predictive of cardiovascular death. The Chamish score is used in 4 coronary segments: the left main, the left anterior descending, left circumflex, and right coronary artery. And it's scored from 0, no calcium, to 3, more than 2/3 of the artery showing calcification, for a total potential score of 12. So here is an example of an LED looking at the extent or the length of coronary calcification in the artery. Less than a third, the score is 1. Greater than a third, but less than 2/3, the score is 2. And greater than 2/3 of the coronary artery length calcified, the score is 3. So 0, 1, 2, or 3 in this LAD is how we score each coronary artery. And this has been validated with the Agatston score by Dr. Burdoff et al. In the International Journal of Cardiovascular Disease in 2014, where he showed that the Agatston score of 300 or greater is equal to a Chamish score of 6 or greater, so severe coronary calcification. So a Chamish score of 6, to review, would be a score of 3 and a less in 3 major epicardial coronary arteries, so extensive coronary calcification. And what Dr. Chamish did is he followed these people and showed that patients with a Chamish score of 4 who had moderate and large amounts of coronary calcium had increased cardiovascular events and cardiovascular death. So we validated what we were doing. We thought it was important that we're doing this visual calcium scoring, and we're criticized for some people who are not doing the Agatston score. So we did a blinded read and compared inter-observer reproducibility with visual estimation on a non-gated low-dose CT of the chest, and found good reproducibility between the two observers with an R-squared of 0.9. And what we also did was we followed these patients who had a coronary calcium score of 0. 30 of the 150 patients with a coronary calcium score of 0 at 6 months had no death, myocardial infarction, and none were readmitted for unstable angina. And more importantly, which we find very useful, is to know that the coronary calcium score is 0, and these patients that we're getting are more obese, cannot exercise, and we're getting much lower quality scans because we're doing chemical stress on 250 kilogram patients, and we're having a lot of attenuation, a lot of shine through, a lot of subdiaphragmatic activity. Anybody feel my pain out there? So the coronary calcium score of 0, looking at this dot plot of some stress score, was very helpful in those patients with equivocal perfusion scans to make a decision that, no, this is attenuation, and this scan is not related to, abnormalities are related to attenuation, not coronary disease. Now there's some distinguished members of the audience that are setting down and planning a trial. That's Dr. Better, Dr. Ellison, Dr. Vitola from Wollongong Hospital, Royal Melbourne, and Curitiba, Brazil. We're looking for any other sites that would be interested in participating in this study to look at the poor man's attenuation correction, visual scoring of coronary calcium on low-dose attenuation correction CT scans, and see what that visual scoring impact is on your interpretation and the diagnostic and therapeutic action based on myocardial perfusion scan alone. And there is some evidence that patients with normal perfusion or normal functional imaging that have significant plaque burden will have a significant alteration in their prognosis. The other speaker showed from the Scottish study the use of platelets and statins improved outcome. And this study from St. Francis Hospital showed that patients with baseline coronary calcium score of greater than 400 had lower cardiovascular event rates on atorvastatin than placebo alone, defined as MI, stroke, cardiovascular death, or need for revascularization. So, routinely performing visual CT coronary artery calcium scoring, or what I like to call the poor man's calcium score, can be done on anybody with a hybrid system that's doing attenuation correction CT. And this information will improve your diagnostic ability, improve study interpretation, and better define the risk of the patient's future cardiac events. Thank you very much for your kind attention.
Thank you, Dr. Stovers. We'll hold questions till the end of the session. So we now invite Dr. Seneviratne to come back again and speak about assessment of ischemia with cardiac CT, CT-FFR, and CT perfusion imaging.
Thank you once again for the opportunity. So I'll be talking about how cardiac CT has dramatically changed in the last few years to be able to not only provide anatomical data, but also functional data. Now, we all know that as interventional cardiologists, and I'm one of them myself, we all love stenting significant stenosis on visual basis. However, Courage and BARI-2 and a number of other trials showed us that that approach is not the way to go, as it does not reduce outcomes. On the other hand, ischemia-driven revascularization has shown in SPECT data in the past, and more recently in FAME and FAME-2 shows that ischemia-guided strategy is far superior to an angiography-guided strategy. Now, in the current era, the gold standard for ischemia is fractional flow reserve. And just for anyone who is not very familiar with fractional flow reserve, if I just spend a few seconds on that, this is an invasive wire that we insert through cardiac catheterization. And what it measures is essentially pressure difference in aorta and distal pressure, and looking at the ratio between distal pressure and proximal pressure under maximum hyperemia. And a value of less than 0.8 is considered the current gold standard for ischemia. Now, cardiac CT, as we discussed before, is a very good anatomical test, got very high sensitivity. And how does cardiac CT perform against this current gold standard of FFR? And these are studies comparing cardiac CT versus fractional flow reserve. And what you can see here is that if somebody got less than 50% stenosis on cardiac CT, there is more than 95% chance that that particular lesion is not functionally significant on FFR. So less than 50% stenosis, you have no concerns that it's almost certainly not going to be FFR significant. But if you got a 50% or more stenosis on cardiac CT, only about 50% or a little bit more than that will be FFR significant. So cardiac CT, while being very good at excluding coronary disease, is not very good at identifying which lesions require revascularization. Now, the researchers have been looking at what we can do to try and improve this deficiency with cardiac CT. And over the years, two strategies have emerged. One is CT perfusion, in a way somewhat similar to myocardial perfusion with SPECT. And the second one with CT-FFR, which is assessing the FFR using cardiac CT. And so let's talk about these two strategies and where they're at the moment. Now, first we'll talk about the CT perfusion. This was first described by Richard George from Johns Hopkins. And as you can see in this example, you can see on the right, volume rendered images in a 53-year-old female showing severe proximal LAD stenosis, and curved MPRs showing the same, and angiography showing the same. And if you look at the top left corner, you can see the rest myocardium with normal perfusion. But if you see the image below that, you can see a subendocardial perfusion abnormality in the anterior wall corresponding to this LAD ischemia. Now, there is also software that's been developed, and you can see the software below that, and which uses a technique called TPR. And you can see blue is what you consider as ischemia. So both visually and from a software perspective, you're able to assess ischemia. Now, this is a relatively simple procedure to do, and if I just very quickly explain, you do a standard cardiac CT, and there is no need to do CT perfusion if you actually have a normal or mild disease. And you would only do CT perfusion if you got moderate or more disease. And what you do is you give a stress agent, typically adenosine or regadenoson in US, and 5 minutes later, you give contrast again, and then obtain static images of stress CTP. The average time spent in the CT department is about 2.5 hours. Now, in addition to this static technique, there is also what we call dynamic perfusion imaging, where what happens is that you take multiple images of the CT myocardium in a cardiac cycle, very similar to MR perfusion. And you can see in the diagram below that, you can actually assess absolute myocardial blood flow, and in ischemia, in ischemic segment, you will see the difference in the myocardial blood flow. Now, what is the value of doing CT perfusion on top of cardiac CT? The real value is, if you remember, the main deficiency of cardiac CT is it lacks specificity in identifying functionally significant stenosis. By adding CT perfusion, we and other groups have demonstrated that the specificity can be increased significantly without compromising its negative predictive value. And what evidence do we have? There are 2 randomized controlled trials of CTP or CT perfusion, and the largest of these was CORE 320, came out a few years ago, and 381 patients, number of countries and hospitals, and the gold standard here was SPECT imaging with a combination of invasive coronary angiography with more than 50% stenosis. And if you look at the area under the curve, all patients, area under the curve was 0.87, and if you exclude patients who had no prior coronary disease, 0.93. So very good correlation with the combination of invasive angiography and SPECT. And these are a number of single center studies, predominantly looking at FFR versus CT perfusion. Again, showing good numbers, accuracy between sensitivity and specificity between 71 to 95%. But of course, these are only single center selected patients. If you look at meta-analysis of these patients against fractional flow reserve, what you can see that CT perfusion compares very favorably with PET and MRI, which were right at the top. However, CT perfusion is not always straightforward. It is limited by number of artifacts, and I'm not going to go into detail in the interest of time, most commonly motion artifacts and what you call beam hardening artifacts, and that makes it very difficult, and they can mimic perfusion abnormalities. So the limitation of CT perfusion is it means that it requires an additional scan, therefore additional radiation, there is additional contrast, and there is of course cost. And artifacts, as I showed you, may mimic perfusion abnormalities, and hence not everyone can read these. So you need expert readers. That's a significant disadvantage. With this background, another technique which has emerged and has become the front line in this kind of field is CT-FFR. Now, CT-FFR is pretty simple, but very hard to imagine how it can be done. All what we require is a standard CT. And it does not require extra radiation, doesn't need change of imaging protocols, no medications, nothing. All what you need is cardiac CT, and by a technique which is called computational fluid dynamics, which I'll explain in a minute, that you're able to assess the fractional flow reserve along any point of coronary tree. Now, if I briefly talk about physiological principles, the first thing to do is to look at the anatomical model, and this requires both human and machine learning, and then we apply a number of physiological equations to assess the boundary conditions and microvascular resistance. Again, I'm not going to go into detail. And finally, then you apply the data into a supercomputer using computational fluid dynamics. And these are the similar kind of methods used to sort of fly an aeroplane or look at the flow of a river, so computational fluid dynamics. Now, this technique was developed by a company called HeartFlow, and they were the primary providers of this technique, which is based in US. And you're able to get the coronary flow, but at a cost. And you have to send the images to them. Now, it's around $1,000 US is the current cost. Now, I'll come back to that. So again, what is the advantage of doing this CT-FFR? Again, the problem is the lack of specificity with cardiac CT. By adding FFR-CT or CT-FFR, you can use either of the terms, you're able to improve the specificity and therefore increase the accuracy without compromising the negative predictive value. Now, there have been 3 large multi-center trials on FFR-CT versus fractional flow reserve, and the largest of these was in 2014 NXT trial, and you can see compared to FFR, area under the curve was 0.93, a very high accuracy compared to invasive FFR. And this has led to FDA approval as an appropriate technique for assessing ischemia in November 2014, and is used clinically in a number of centers in US and Europe clinically at the moment. A number of studies been done by HeartFlow to establish this technique. This includes studies showing that having high calcium score does not impact on the accuracy significantly. It has also shown studies in the main study being platform, showing that if you apply this technique to patients who are already waiting for coronary angiography, you can significantly reduce the number of angiograms required. So in this platform study, by applying FFRCT to patients who are already waiting in the cath lab waiting list based on functional imaging, FFRCT is able to reduce more than 80% of negative invasive angiograms and did not miss significant findings. And there was no adverse clinical events in patients whose invasive angiograms were deferred or cancelled. And because of this advantage, it is also been shown to reduce cost. Now, how does it compare with the existing tests? So this is comparing against cardiac CT, stress echo, SPECT, invasive angiography, and MRI, and FFRCT actually is right at the top. So let's look at, is there any data between CT perfusion, which I talked about before, and FFRCT? And the major trial is going to be presented at EuroPCR in a few weeks' time. And our center has got significant set of data that's currently under review, 99 patients, 194 vessels, CT perfusion and CT FFR in the same patients. What you can see is FFR-CT is significantly superior to CT perfusion and cardiac CT. Not only that, it's able to provide information on functionally significant vessels, this may in the future be also able to guide us in revascularization. So it is likely in the future that you will actually have a CT which tells us that there is moderate or more disease, and then you do the CT FFR, and then you'll come back and say that this lesion is actually functionally significant, and if you insert a 3x24 stent, you will make the vessel FFR negative. So what are the limitations of FFR-CT? And of course, there is a large number of data coming, but still it requires more prognostic data. In comparison against other non-invasive modalities is still coming, but still only limited data. The main problem is the logistics and cost. You have to send the CT study to HeartFlow, and usually about 24 hours turnover time, and the cost is over $1,000 US. So to overcome this limitation, there is a new technique which has come about, which is called reduced order CT FFR. And several vendors have developed this technique, Philips, Siemens, and Toshiba. And HeartFlow has come to an agreement with at least Siemens, so therefore that Siemens will be progressing their technique, but under the guidance of HeartFlow. So what I'm going to talk about now for the next few minutes is a technique developed by Toshiba or Canon along with Monash. So in this technique, the anatomical model is basically you have obtained the same anatomical data. The boundary conditions or physiological conditions are different. You're looking at vessel deformation. I'm not going to go into detail in the interest of time. And main difference is the numerical solution. So when you apply the computational fluid dynamics, there is no need for a supercomputer. Therefore, you do not need to send any CT to another center in another country. You do it yourself, or your technician can do it. It takes half an hour to do it. Now, again, the main differences, the vendors, of course, different. The different boundary conditions being used. Microvascular resistance is different. And again, as I said, HeartFlow, you need a supercomputer and offsite analysis. With the reduced order model, you can do it on a desktop computer, on-site point of care. Compared to about 4 hours with HeartFlow, this is about 30 minutes. And of course, the cost being significantly different, and we don't know what the cost will be if and when this technique becomes mainstream. The initial validation was published by our group last year, again showing the area under the curve of about 0.88. So very, very satisfying, but of course, small numbers, single center study. If you, to show a couple of examples, in both examples showing intermediate stenosis, both in LAD, one showing anatomically which looks significant, but functionally non-significant, as shown by both FFR and by this reduced order CT FFR. So if you want to read more about when to use CT perfusion, what are the advantages with that technique versus CT FFR and these things in more details, Johns Hopkins and us have published an article recently in European Heart Journal. And in conclusion, CT perfusion is feasible and accurate, but limited by the need for an extra scan, artifacts, and the requirement for expert readers. CT-based CFD techniques or HeartFlow CT-FFR is feasible, it is reproducible, and it's highly accurate when compared against the gold standard FFR. The preliminary findings show that FFRCT guided approach to intervention and or to exclude patients who require further investigation is safe, and it improves patient selection for invasive catheterization in a cost-effective manner. Although it is cost-effective, there is a significant added cost when you apply CT-FFR, as you have to spend over $1,000 to obtain this data. As I said just before, while FFRCT is the largest body of evidence for this particular kind of modality, it remains limited by its processing time, which is usually overnight, and by its cost. Larger multi-center trials are required in demonstrating the value of reduced order CT-FFR, which I just showed. If this proved to be at least equally or at least close to the FFR-CT, this can significantly change how we practice medicine. So you'll be able to do the cardiac CT, be able to assess whether the patient's got mild disease or non-obstructive, then no further testing is required. If the patient got moderate or more, then you apply desktop computer CT-FFR assessment and then work out that lesion is significant, and then you can decide what to do with it. Thank you once again.
Thank you, Seni.